Stage. Ma'am is from AIMS Jodhpur and presently she is the head of the Department of Pathology.
So much. That's just administrative.
Yeah.
A very good afternoon and namaste to everybody who stayed till now to listen to this session. And thank you so much to the organizers for inviting me. Thank you. And without much ado, I would like to go on to my presentation. I have very basic cases. If you're expecting something out of the ordinary, it might not be that. But thank you. So I have called this session a medley of HNE with a little brown in the era of NGS. So nothing very hi-fi, just a little bit of brown, and I would like the audience to be interactive. So, and maybe not from AIMS if possible, because they might have seen these cases. So the disclaimer is that all these images are from our own patient resources, and 2 images have been borrowed from Wikipedia for the purpose of illustration, and this is under the Creative Commons license. So this is the list of cases. I'm not sure if I'll be able to cover all, but this is the list of the cases. So I have 5 cases with me. So the first case, it's a busy slide, so this is just the presenting features. So the first case was a pretty recent, am I audible to everybody? Okay. So the first case is a 65-year-old male who had difficulty in walking and giddiness for 15 days. So again, that same cat is around. And this patient had headache and truncal ataxia. When he presented to AIMS Jodhpur, his Glasgow coma score was pretty low. So he's a known opium addict and he has no other comorbidities. He arrived with a brain imaging done from outside the institute, which suggested a cerebellar space occupying lesion. I think maybe it's going to. So the surgical team planned for a CSF diversion ventriculostomy, and with that, they thought there would be improvement, but the patient dipped further. The verbal commands went to nil. A repeat NCCT head was done. I like this cat. So in the immediate post-op period, the patient's condition worsened. And unfortunately for us, he passed on the next very day. But in that period, they could do a gross total excision of the tumor, which was sent to us. They called it a soft, suckable, moderately vascular tumor, which was not bulging on the surface. So as we can see, I'll use the pointer here. I'll use the cursor here. We all can see the cerebellum. Yeah, and we can see. So any resident, what is this? Anybody, I mean. What do you think the images? These are HNE stained images. So any thoughts on the lower right hand corner? So otherwise I'll keep on talking. So as we can see, these are some necrotic, hemorrhagic appearing areas. No, pretty dirty looking, not something very nice. So again, as Dr. Nirupama and many others have showed, so we have these giant cells. So more giant cells, but along with the giant cells, what else can we see? We can see a lot of perivascular cuffing, right? So we have a lot of mixed, in the picture on the top, we can see plasma cells. I'm not sure whether they are apparent, but to me they are. So we have a lot of multinucleated giant cells. And as we know, when we see giant cells, we have to see uske andar kuch dikh raha hai ki nahi, right? So that is what is being taught to us from the beginning. So please look at the giant cells. Any idea what this could be? It's a monkey. It's a monkey for everybody. It's a special sort of monkey. No. Okay, so this is the image I borrowed from Wikipedia. This is the source of the lesion that I'm going to show to you. So can you see what Dr. Nirupama showed in the interesting? Can you see the thing right in the center here? Anybody? So that's a trophozoite. That's a trophozoite for us with a large, it's a large size cell with a central with vesicular nucleus and a prominent nucleolus. And you can see a mixed inflammatory picture. Look at the one, you can see so many trophozoites once you start seeing. And the speciality of these trophozoites is they just start to eat the vessels and cause a hemorrhagic necrotic vasculitis. So just look at this. Can you see the vessel on the top? And look at the way these trophozoites are just going around the vessel and they're eating it too. So this is, and look at this here. So many trophozoites, the slide was studded. In fact, when we told the clinician that it is not a tumor, they wouldn't believe us. But by the time the patient had already passed on. So just look at these structures. Can you see all these fusiform or these, big looking structures, very large cell, 40 to 50 microns. You can easily pick them up even on an HNE. So the Masson's has not come up well, but you can see the vessel in the center and all the trophozoites around it. So one thing about amoebic trophozoites in the brain is that for the variety I am talking about, they will not stain very well with either PAS or with Masson's. Thank you. I'm okay. So what the final diagnosis suggested by us was it's a granulomatous amoebic encephalitis, most likely Balamuthia, right? So, and we sent ribbons of this blocked paraffin material to PGI Chandigarh, the Department of Medical Parasitology, where Dr. Abhishek very kindly did it for us. And he confirmed that on nested PCR that it was positive for Balamuthia. Just a little thing about, in this region, why it is important. This is possibly my colleague, Dr. Divya, had a similar case this year only, and we had another case. Hers was a young male who presented with classic skin lesions, and our patient came pretty late in the day with about a month-old history. And so we need to know about entamoeba yahan pe, because it's an upcoming problem, and around 200 odd cases have been recorded in the world. So these are free-living amoebae. I'll not go into, there are several genus. So we have Naegleria, we have Acanthamoeba, we have Balamuthia, and we have another variant called Sapinia. So almost all of them, they come to us pretty late. They have a poor prognosis. Naegleria, has a fulminant course. The others don't, but the prognosis is poor. So I'll not go into Naegleria. I'll just tell you what we called this case. We called it granulomatous amoebic encephalitis. And it is caused by either Acanthamoeba. Many contact lens users, and many of us might be doing neti with that neti pot in the morning for clearing the sinuses. Even that has been found to contain free-living amoebae. So just a word of caution here. So what we have to remember is that when we talk about Acanthamoeba and Balamuthia, these tend to primarily cause disease in immunosuppressed or debilitated patients, which ours was not except for the opium addiction. And Naegleria, usually the patient will have an exposure to swimming in freshwater bodies. And as Purohit sir asked Borges ma'am, कि इतने लोग जैसे नदी में घूमते हैं लेकिन होता एक ही को है, बहुत कम होता है. What is the reason? So even they are looking into it, So I showed you this monkey, and this is nothing but so we have an Indian called Govinda Visveshwara. He was the person, in the honor of his late mentor, Dr. William Balamuth, he called it Balamuthia. And in the, he named after this monkey. It was a pregnant monkey, and it was called a mandrill monkey. So this is nothing but a mandrill monkey, which is called Mandrillus sphinx. Iske andar, she was a pregnant lady when she died, and they autopsied the brain. They saw these organisms which were not matching with any other free-living amoebae. So that is how they called it Balamuthia mandrillaris. Just a little bit about history. So that was the first case. This is something which I have picked up from one of my slides of the pap smears. Anybody? In the RAJPATHCON 2023, somebody presented a similar case from a patient who went to Africa. It looks like, something weird. So what could this be? Anybody? Believe me, it's not fancy. It was right there on the slide. So this is a pap stain slide of a cervical smear, and this is nothing but a plant trichome. We have to be aware of this because, in these days with all sort of global movement, we do get patients with my friend Dr. Lisa from Parter, she presented a case where a patient visited Africa and came back with a cystic swelling and they saw similar structures. So I just want to tell you that this is nothing but a plant trichome, right? Trichome. And this is the image I've borrowed from Wikipedia, the one lower down. So that's case 1. Any questions on this? So Balamuthia mandularis. So I'll come to the second case. This was a 15-year-old young boy, a school-going child, who initially had a small swelling noticed incidentally for about 2 months on the left side of the neck. Yeah, initially about 3 by 3 centimeter, progressed over 2 months to attain a bigger size, 11 by 4. So there was no significant history, nothing except for this swelling. And on examination, as we see, when there is a neck swelling, you look for deglutition, you look whether it was pulsatile, there was nothing. So we do direct FNA, we did a direct FNA, a 12 milliliter of turbid yellowish fluid was aspirated. Any thoughts so far? Turbid yellowish fluid, young boy, 15-year-old, left side of the neck. Any thoughts? Any cystic swelling? You can name any cystic swelling in the neck. Excellent, very nice. So sir has said a branchial cyst, which is what we thought too, very right. Thank you, sir. So just look at this. So a beautiful H&E stain to show you the cholesterol plate crystals, right? And some inflammatory cells in the background. The Giemsa stain smear showed you eosinophils, which I'm not sure are very apparent, but it showed a lot of inflammatory cells and a fluidy background. So with this, we also gave a diagnosis of a benign cystic lesion, possibly branchial cyst. So obviously it is not branchial cyst if I'm standing here and showing it to you. So this is the clinical image. I want to thank my colleague Dr. Darwin for sharing this. So just look at this huge thing. It was for the first time I'd seen something with a tail, with a tail-like appendage. That's a huge cyst on the top with a tail-like appendage extending right down into the mediastinum. And when we cut it open, that is what we saw, a very darkish looking image, but that is what it's unilocular. It's unilocular, it has got a variably thick wall, some whitish looking areas, you can see them at the periphery. So with that, when we went on to the microscopy, any thoughts now? Still branchial cyst, maybe, or another cystic lesion of the neck. So as rightly said, we will discuss cystic lesions of the neck here. Thyroglossal cyst, though it wasn't in the center, it was lateral and it was not moving with deglutition. Branchial cyst, very right. But it's superficial, lateral, rarely extending to the clavicle. This was one going right to the mediastinum. Lymphangioma, it can be cystic, but these are brilliantly translucent. So bronchogenic cysts, epidermoid cyst, cystic lymph nodes, and rarely thymic cysts. So when we took the microscopy, this is what we found. As you can see on the top, I wonder how this will work. Yeah, okay. So yeah, so is it? I'm not sure it's working on the screen, but that's okay. At the top of the image, you can see the lining. So that's the lining epithelium saying it's a true cyst. And we can see all these dilated blood vessels, a lot of reactive follicles, with germinal centers. That was nothing but, maybe FNA induced or maybe chronic long-term hemorrhage. So a lot of cholesterol crystals with foreign body multinucleated, foreign body granuloma and cholesterol deposition. So here come the tricky part again, a lot of proliferated vessels. Yes, so what do we have here? What are these structures which I pointed out with the yellow arrow? Maybe it's not very apparent, the picture quality might be a bit tricky. These are nothing but Hassel's corpuscles, right? So we have a lot of Hassel's corpuscles. Maybe in the center you can appreciate it better. So we had a lot of Hassel's corpuscles in this image. It's there on the upper right hand too. So with that, we went for a diagnosis of a cervical thymic cyst. Yeah, the age is correct. And the lesion was extending right to the mediastinum. Also associated with this was a parathyroid gland, because as we know, the parathyroids and the thymic, they get their origin from a common thing. So these tend to be diagnosed clinically as branchial cysts, so right. The origin can be either from an ectopic remnant of the thymus when it undergoes secondary degenerative changes, or origin from cystic degeneration of the persistent thymopharyngeal duct as it moves down. So I've already told you this, but we had parathyroid tissue. I have not put it in the image, But both thymus and parathyroid glands are derived from the third and the fourth pharyngeal pouches. That is how they move together. These are mostly elongated and range in size from 1 to 26 centimeter. Ours was 11 centimeter. They occur in region between the angle of the jaw to the sternum. Anybody, what is this? This, we had a specimen of urine recently, and I wanted to put the video, but there was a lot of noise and excitement in the background, so I just cropped that video and got this. Anybody? This, I think all of us will get to see. This is from our own department. We got a urine specimen, and that lady was, I think, admitted in the ICU possibly. And the urine had many of these creatures. Do we agree it looks like an organism? Actually, I put an iodine stain so that it could highlight as yellow. Otherwise, वैसी दिख रहा था. So no, it was in urine, but it's a contaminant. So that is why I want to show it to you, because all of us might get to see it one time or the other. You know, there's a creature called a water bear. It's one of the oldest creatures known to mankind. It is tardigrada. Tardigrade, tardigrada, or a water bear. So tardigrada की क्या खासियत है? It can survive extremes of temperature, hot springs, Antarctica, desiccation. 10 साल उसको ऐसे पानी नहीं मिलता. The only place where tardigrades do not survive is the human body. Right? So this is a contaminant which most of us will see from the water which we are getting. This is nothing but a water bear or a tardigrade. And you know, because we put that, it was looking very cute moving around. It had these, you know, it highlighted its red eyes, the iodine stain. So this is nothing but a tardigrade or a water bear.
What is this contaminant?
It's a water bear. So it's an 8-legged micro animal. It's also called the moss piglet. ये pig जैसी शक्ल है और bear जैसा दिखता है. So this is, I just wanted to show it ऐसे, you know, to break these. So case 3, so this case is from a 25-year-old lady. She had a swelling in the oral cavity which was present for about 10 years. 25-year-old lady, swelling in the oral cavity for about 10 years, initially small. She came now because it was growing larger and causing difficulty in swallowing. Otherwise she had no problem. A clinical diagnosis of a hemangioma was made. So the swelling was excised by the ENT department and sent for histopathological evaluation. This is about a 5-year-old case. So this is what we saw in gross. So can anybody describe? Does it look like classical prototypical hemangioma to any one of us? Yeah, maybe if it has bled a lot, chronic bleed. Sorry? Smoke. No, it's a 25-year-old lady. I don't think she's smoking, but maybe she is. I wouldn't know. That's my judgment talking. But so, you know, we've seen, it's almost a circumscribed mass, but there are yellow areas, there are very ugly looking blackish brown areas, white surface. So it's something with a mixed picture. Having shown that, we will come to, so this is what the microscopy showed. Can any one of you describe a few features? It's just a mutual exchange, कुछ भी बोल सकते हैं. ये क्या, ये structure तो सभी ने देखा है. Excellent. So that's a Samoma body. Very, very nice. And you can see some fat on the top. We can all see blood vessels, and we can see some blood vessels, fat. We can see some calcification here. And what else can we see which is so brown? Excellent. So somebody said hemosiderin, somebody said melanin. I agree with both, and I'll show it to you. Very nice. So if you see, we have a tumor. We have a lesion which has melanin, which has maybe got hemosiderin, it has got blood vessels, it has got some fibroadipocytes, and it has got this vaguely fascicular lesion, spindle cells moving all over the place. Anybody? We see the structure in the spleen and chronic venous congestion. Excellent. So that's a Gamna-Gandhi body. Gamna-Gandhi body can be seen anywhere where there is chronic hemorrhage, some deposit of calcification, fibrosis. So you can see fibrosis, you can see, those calcific strips, and we can see some hemosiderin. So this lesion had a lot of bleed, so they were not far off when they said it's a hemangioma, some inflammatory cell, some fibrin. Any thoughts so far? You have a lesion which is spindled, not very atypical looking, with hemosiderin, with melanin, hemorrhage, some fat in the oral cavity. Any guesses? Any guesses? कुछ बोलने से तो कुछ भी बोल सकते हैं. Sorry? नहीं, even we really broke our heads over it. So, as somebody very rightly said, so we've done a pearl stain to demonstrate the hemosiderin. So, we have hemosiderin on the right hand side, and what is not staining is the melanin. Right? So, any thoughts so far? A circumscribed lesion, long standing, 10 years. Oh, excellent. Who said that? Very nice. So, sir is on the right track. Thank you. So, just look at this. So, I said I'll throw a bit of brown inside. So, we did IHC for S100 protein, which is very beautifully positive. IHC for HMB 45 because there was a lot of melanin in the lesion, very nicely positive. I told you it's a 5-year-old case. We were not doing great, too many antibodies that time, but we did a Ki 67 to show whether it had a low proliferative index. We did a CD34 that was negative. We did a EMA that was negative. We got calcification. We did an SMA. We did a CD117, all negative. Any thoughts so far? So if it's a neurofibroma, we'll usually get a CD34 positive. Or if we think if it's a pigmented DFSP, it again would be a CD34 positive. It will not have fat. It usually does not have Samoma bodies. Any thoughts so far? Sorry? Granular cell tumor. Okay. Anything else? So I said it was negative for a lot of things. But yeah, very right. What else? Why not malignant melanoma? Somebody said, okay. So I didn't show you any prominent inclusion like nucleoli. I showed you Samoma bodies. But yeah, and I said the KI index is very low. It's not even, the labeling index was not even 1%. Okay, so with that, there is an entity, as we know, don't go too far, So this is just an overview of the same thing again. So, yeah, so I've written something. So a diagnosis of a Psammomatous, it was called a Psammomatous malignant or a Psammomatous melanotic schwannoma, but now they've changed the term. They call it malignant melanotic nerve sheath tumor. But they are not sure about the malignant potential even now, or the metastatic potential. And we should remember that we called the patient back to the hospital. She's from beyond Nagaur. So she came, she was examined for other endocrinopathies, skin lesions. She did have a few freckles and macules, but nothing significant. So as we know, 50% of these cases are associated with Carney's syndrome. But she, as of maybe 2 years back, she had no such features.
I agree with this one, the second one. The diagnosis of Psammomatous melanotic schwannoma.
Yeah. Thank you. Yeah. Thank you. But actually, sir, as we all know, there is so much of updation, so many changes going on. इधर से नाम बदलते रहते हैं for whatever purpose. So they've chosen to call it, this term is acceptable, but they've chosen to call it, as I said, malignant melanotic nerve sheath tumor. But even they are not very clear about the metastatic potential or how it will behave long term. So it's a rare tumor which occurs in the posterior spinal roots. I think I'll skip this because it's got a syndromic association. That is why possibly the need to look for. In the newer 2023, they've called it a malignant melanotic nerve sheath tumor, and they're still not very clear as to how it will behave. Yeah. Thank you. So anybody, what is this? Again, another googly thrown in. So this was a case of oral squamous cell carcinoma, and this patient was really far gone, and he had ulceration of the skin. So can you see this weird looking structure? This was the first case I did as an intern. मेरे surgery के resident ने बोला था तुम ये करना आके. So this patient had maggots on his leg, and he made me scrape that. So this is a maggot. This is how a maggot looks on microscopy. Can you see those weird looking appendages at the periphery? So this patient, he ulceration of the lesion with maggots inside. So do I have time? Oh, okay. Otherwise you can cut me short. I'm So this case is with a 25-year-old lady. This I think most of us will tell. Swelling in the right medial aspect of the thigh for 3 months. It was painless swelling, increasing in size, and FNA was done. So the FNA shows mainly a hemorrhagic background, but oops, sorry. Yeah. So I think I'll keep this aside. So this is. Anybody want to describe these cells? Large cells, yeah. Large cells, abundant, foamy, vacuolated cytoplasm with an eccentric, large round nucleus. Maybe prominent nucleoli, some bare nuclei in the background. Any thoughts so far? 25-year-old female thigh swelling. I'm sure you'll hit it right on. So again, a large nucleoli on the top in the bare cells. Again, similar cells, and that's the cell block we made. So cell block showing very pink looking cells which are large. Sorry. Pink looking large cells in a hemorrhagic background. Excuse me. Now you can tell what is this. I've made a star for you to see. There's a yellow star which will show you. And that's a PA stain slide. Periodic acid shift. 25-year-old lady, thigh swelling. And what is this pattern? Very nested looking pattern with some capillaries. What are these? Can you see those deep pink color, elongated structures? If I tell you, can you see that star? So there are these sinusoidal like capillaries separating these nests of large cells. So what is it? So the differential diagnosis could be a paraganglioma, granular cell tumor, adrenocortical, kuch bhi, rhabdomyosarcoma, clear cell sarcoma, perivascular, pecoma. But see, keeping all that in mind, we did these IHC. The first IHC is for Desmond. Desmond is dead. Then we did what? Anybody, can you guess? I have written, no. Can anybody guess this IHC? We have some fat which is staining positive for that IHC. So, ma'am, I think Ajay ma'am is saying, so this is S100 protein. So, S100 dead negative. What is that IHC? Which is showing nice, beautiful nuclear positivity. It's TFE. Right? So, I'll just show you. We have an IHC for TFE because our diagnosis was alveolar soft part sarcoma. Right? So, it's a rare tumor of the deep soft tissue, comprising about only 0.5 to 1% of all soft tissue tumors, usually young women. Metastasis, the patient might not give you history, might have a lesion in the brain or the mediastinum, lungs, many years down the line. So what I was showing you were those rod-shaped crystalloids, which come beautiful. Usually you might not get, but we got beautiful ones on the PS stain. So that was just to show you that. I've described the picture, large polygonal cells, etc. So this is just to tell you that there was a TFE3 gene which forms a fusion gene partner, and that is what was picking up on the nuclear positivity. So case 5, this is the last case for the day, and thank you so much for listening. So again, a 53-year-old lady with a swelling in the left submandibular region for 3 months. And she also had complaint of earache since 15 days. On examination, there was a firm, non-tender swelling in the angle of the jaw with multiple foci of calcification on ultrasound. So this is, we do direct and guided FNA. These days it's shifting more to guided, unfortunately. Can anybody describe these clusters? Do they look good to us? Do they look very benign and banal? No, they don't look good. Though they are large, they are ugly looking. Look at the nuclei. Even at this, we can see the nucleoli, we can see mitoses, which I've pointed out with the arrow. So again, very cellular clusters, very cellular. And even in, FNA, we said we picked up calcification. We picked up prominent nucleoli, moderate to abundant amounts of cytoplasm. Any thoughts so far? A high-grade lesion, submandibular gland. Prominent nucleoli, very cohesive. No, I've not shown you any other cells. No squamous cells, no background, no bare nuclei, no acinar, nothing. Very cohesive. So, I'll come to So what is the differential diagnosis when you come to a salivary gland? It might be a primary. It could be primary, it could be metastatic. So primary salivary gland neoplasm with high-grade transformation. You could have a high-grade MEC, epithelial myoepithelial carcinoma, adenoid cystic, didn't look like that, adenosquamous or intraductal. So again, this is a list. It's all available. I'll not go into this. This was a cell block. I was waiting to show this slide. So beautiful cell block. I think most of you would agree. And you can see nice pink cytoplasm. Abundant to moderate amounts of, eosinophilic to oncocytoid, if I may, cytoplasm. Large nuclei with a prominent nucleoli. Background is hemorrhagic. What IHC have we done? So it's membranous IHC. Any carcinoma in the salivary gland which resembles something in the breast, and you use the same IHC in both places? Very right. Some people are whispering. So this is a HER2/neu IHC. So it's a beautiful HER2/neu positive. We did a dog 1 that was negative. We did a 117 that was negative. So any thoughts so far? Salivary duct carcinoma. So this is when we got the excision specimen. This is exactly what it showed. And please tell, this is not oncocytic. Why? Because we know salivary ductal carcinomas do tend to have abundant amounts of bright eosinophilic cytoplasm. Just look at the nucleoli, they're giving you that look. Sab aapko ghur rahe hain. So they are large nucleoli giving you that look. And as I said, we picked up the calcification on even FNA, we wrote it in our finding. And by that time we didn't have an ultrasound, let me tell you that. We also work like that. So we can see the calcification in the image on the right. And what else do we see in this? So we see very crazy looking cells. So again the HER2, HER2/neu. What is this? Anybody? Once again. What is the structure and what do you think might be the structure which has taken up so much of brown dab in this? I told you it was going to the ear. So what am I trying to tell you? There could be some. I'll show that in an image. So this was S100 protein, which was negative in the tumor cells and it was positive in the nerve funicle. So this is an androgen receptor. So beautiful androgen receptor positivity borrowed from the WHO Blue Book. So that's a cytokeratin 7. If you can see all the epithelium that is staining with the cytokeratin 7, and we can see the nerve funicle here at the bottom right, the big nerve. So we had a lot of perineural invasion in this case, right? So the final impression given was a salivary duct carcinoma. So as I've already told you, these are invasive tumor cells with ample or abundant amounts of eosinophilic cytoplasm, forming cords, nests, and cribriform glands. And nuclear cytology you've seen, it is high grade with nuclear pleomorphism. And there are several variants. I'll not go much into the theory, it makes no sense. So IHC, androgen receptor positive, GATA positive, CK7 positive, HER2/3 may come positive in 10 to 35% of cases. Prognosis is usually poor. And one of the factors is a perineural invasion, which we had a lot of. So these are my references for these cases. And I would like to acknowledge all the patients. Unfortunately for us, learning is at the expense of all the patients who come to us in miserable states. My colleagues who've, either they have gotten the histopath or they've gotten the cyto, the senior and junior residents and the technical staff. And this is the final slide. I would like to invite all of you to please register for CytoCon 2024. It is at AIIMS Jodhpur. Next year, 16th to 19th November, the dates are already blocked. We will have international and national speakers both. This is our auditorium. And so this is it. And thank you very much once again for calling me. Thank you.
Thank you so much, ma'am. Enlightening talk, packed with valuable insights.
Thank
Now
you
I
so much, ma'am,
request-
for your nice presentations. And these rare cases. Generally, in salivary gland duct carcinoma, we see the comedo patterns, which we'll see in the breast most commonly because they are advanced.
Because this is just a snapshot, I can't show the whole case, so we just pick up some.
Yeah.
Thank you.
Thank you.
Hello. Madam, I had a question actually, or rather I want to add. The first case which you told about the free living OMB, people have got very little, especially the pathologist has got very little knowledge about the free living OMB. It is actually Naegleria fowleri and the Hartmanella. I had a very interesting case in Nigeria. The patient came with meningitis, and we isolated the Hartmanella and Naegleria fowleri in the CSF, and we thoroughly and deeply inquired about the case, and we came to know that that patient was traveling on the highway, and he was a Muslim patient, so he stayed for prayer, and it took the snake. So it actually penetrated the cribriform plate. It went to the brain, and the CSF was infected with the Naegleria fowleri. We did the culture on the non-nutrient agar, and it grown very well.
Beautifully, yeah.
We have published it
So,
in
yeah.
American Journal
Very
of
nice.
Clinical Parasitology.
Thank you so much. Thank you. As sir has very rightly said, that's one point which we all need to know. CSF, you will usually pick up Naegleria, but
Yeah.
not Acanthamoeba or Balamuthia. Yeah. And what is the other way to see those organisms? You can even, you don't
They
need.
float actually. They
Absolutely.
float very
So you
nicely.
see them, moving with their pseudopodia or whatever they are called.
Actually, they are contaminant.
yes,
Most of the time,
absolutely.
they was
Free-
there. We use the dirty water.
You can even warm the water.
If
yeah.
urine specimen, this tube are not washed properly, you will see this amoeba.
Absolutely. Thank you.
They are contaminant actually. They are contaminants basically.
I would request
We
Dr.
have to
Vyas sir
look
and
for
Manju ma'am to
non-nutrient
please
agar.
felicitate.
Put them on non-nutrient agar
Poonam ma'am.
culture. That will be useful.